Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have our first CEU episode of this season.
Yes, we do. And we are doing a familiar topic if you travel back in time and go back to season 1.
Which actually, this was our first education episode
we've
ever done.
I actually didn't know that. Fun fact.
Yes, it was Achilles Tendonopathy. So what's really exciting about this is it's been so long since we've had it that we could actually kind of do an update episode. So it's been about 5 years-ish. So look at 5 years worth of updated research.
How cool. So like we said, this is a CEU episode, and it is a Category A CEU episode, which all of our CEUs are currently Category A. Thank you so much to Athletic Training Chat and Clinically Pressed. If you go down to the show notes, there's the website of clinicallypressed.org/courses, I believe, and you can check out all of our courses on there. The latest 5 episodes will always be free, and then past episodes are really affordably priced, like $3, $5. So then you can help support the show as well. If you would like a video tutorial on our Instagram, we have a pinned post that says how to get to your CEUs, and it literally has us going through and enrolling in the cart, and it shows you the whole thing. So check that out. So what are our objectives for today, Randy?
Yes. So we're going to try and expand on kind of what we talked about in that very old episode that we did on Achilles tendinopathy. So we're going to describe the pathomechanics of insertional Achilles tendinopathy. Our last episode was really geared towards more midportion. So we're going to try and expand a little bit more and talk about another type of Achilles tendinopathy. And we'll identify altered motor patterns and tendon structure as a consequence of Achilles tendinopathy. And then we'll discuss updated evidence on rehab concepts for insertional and midportion Achilles tendinopathy.
I'm going to be honest, when I was newly certified, I don't think I really paid attention to the difference between midpoint or insertional Achilles tendinopathy. And it wasn't until I was referring an athlete who had just chronic Achilles tendinopathy. We did everything we could. And it wasn't until one of my docs asked, as over text, if it was insertional or mid substance. Mm-hmm. And that, simple question, completely changed, oh, this actually does matter, the difference between the two.
And we'll talk about how it makes such a huge difference and how treatment for one could actually be not great for the other. So as with any of these type of episodes, we got to start with some anatomy. But again, we did a pretty in-depth anatomy of the Achilles tendon in that older episode. So this is going to be just quick review. So like we said before, the Achilles tendon really looks more like a braided rope. It's not just this flat sheet of tendon that just comes down what kind of looks like in textbooks, right? So it actually has a spiral component to it. And what's really unique about this is each tendon of the triceps surae, so that's the lateral gastroc, medial gastroc, and soleus, all can be individually separated. So you can actually find the different components, this tendon goes to the medial gastroc, this one goes to the soleus. And what this is referred to as in the literature is subtendons. And these subtendons do actually have the ability to slide and glide against each other. So if you think about it, there could be some maybe issues between maybe them not gliding as well between each other. So that's really kind of the quick kind of anatomy to just kind of set the table for what this episode is going to kind of be about and understanding how the Achilles just kind of functions.
Okay, so you just talked about the anatomy and how the tendon looks more braided, and so we have this slide glide. Mm-hmm. How does that translate into mechanics and pathomechanics?
Yeah, absolutely. So really how Achilles tendinopathy happens, and just probably any tendon in general, is there's just an overload of the tendon. And one concept that we brought about in the first episode on Achilles tendon was this idea of force sharing. So basically the different muscles basically contributing all together to absorb and produce force. So if one's lacking on that, right, another part of the tendon is going to have to take over. So that's kind of that idea of each tendon working individually. So basically the tendon gets overloaded. tendon's not able to repair itself before you do the next bout of exercise, and if this just keeps happening, tendon becomes damaged and weakened. And there are some characteristic signs of Achilles tendinopathy, right? You can see what's referred to as increased neovascularization, which is basically like new blood vessels forming within the tendon, and that's to get the inflammatory mediators there to help kind of the repair process. You can see more fluid in the tendon, so there's a lot more liquid, more water in the area, because again, some swelling, but also trying to get fluids basically getting trapped there. And this causes that increased cross-sectional area. So if you read about it, you always talk about, oh, the tendon looks thicker, the one that's the involved side.
Because it is.
Because it is. Exactly. It has more things happening to it. And another one that I thought was really interesting is you see a lot of decreased tendon stiffness, right? And a lot of times when you think of that, you would think, oh, well, shouldn't that be good, decreased stiffness? But the tendon has to be stiff because that's what tendons do. They absorb and then recoil, right? They're supposed to help us with the efficiency of movement, efficiency of producing force. So reading that, I was kind of thinking like, well, if we're starting to see a breakdown of collagen, that collagen is what's usually pretty rigid. Well, if that's starting to weaken and get damaged, you could see tendon becoming less stiff.
Which makes sense.
Yeah.
So can you go back to what you were talking about between how midpoint and insertional can be so different?
Yeah, so how it's defined in research is midportion Achilles tendinopathy is pain on the Achilles tendon that's 2 to 7 centimeters proximal to the insertion of the Achilles, which, I mean, I don't know how many people are starting to pull out rulers and stuff to be like, oh, wait a minute, that's a centimeter or a centimeter and a half. But just know, it's just a little bit of ways, just not over that calcaneus. And then the insertional is
just to give you perspective in inches, I think a centimeter is 2.5-ish.
I think you're right.
2.5-ish centimeters makes an inch, just a little bit over 2.5. So we're talking about just an inch beyond the insertion point.
Yeah. Yes.
Is what we call midportion.
Yes. And again, like I think most people are pretty familiar with it, probably closer to that 7-ish centimeters when they think of midportion. But yeah, it's a little bit of a range. And then insertional, of course, is just within that 2 centimeters. So basically it's where you feel the tendon join the bone, that's it. The one thing that's a little bit unique with insertional, because midportion tendinopathy, again, it's just the idea of, oh, it's just, tendon's just overloaded. And that's kind of the same for insertional, but the way it happens with where the Achilles tendon inserts is quite unique. And that area isn't just exposed to like the tension from like plantar flexion, being forced to stretch, eccentric load, like all that. It's also exposed to compression. And this compression is basically the calcaneus compressing the anterior side of that Achilles. So something a little bit different, a little bit more unique. And it is actually a consideration, too, when we start talking about how do we treat this? How do we kind of do our rehab? Because that compression is noted when you're in full dorsiflexion. So if you bring your ankle into full dorsiflexion, that compression is really at its maximum against the anterior side of the Achilles.
It's giving like plantar fascia vibes.
Kind of. Yeah. And the bummer is like, again, I don't want to spoil it for the rehab part, but like, one thing you always tell people, well, not always, but like one treatment of Achilles tendon issues could be, oh, well, stretch. Well, if you force yourself into full dorsiflexion, all you're doing is recreating the compression for insertion. So that's why knowing insertional Achilles tendinopathy could make a huge difference.
So then it would probably be better to work manual therapy of the calf to get length rather than a true dorsiflexion stretch.
Yeah, for sure.
Noted.
Duly noted.
So regarding deficits associated with Achilles tendinopathy, would you say that those are kind of the same generally between no matter where it is in the tendon, or are those going to look different depending on where it is?
That's a great point. I didn't see a ton that actually compared the two. A lot of times it's either they just looked at insertional Achilles tendinopathy and what's going on, or midportion, or they kind of grouped them all together in the thing and just called it Achilles tendinopathy. So it was really kind of hard to pull them out. But I think a lot of them do kind of align with each other, depending on what the study kind of looked like. Because with any injury, right, there's going to be deficits, right? We know that the motor system changes, the muscle tissue changes. So this is basically what we're going to try and target with our rehab. And what you see with Achilles tendinopathy is, again, decreased stiffness of the Achilles tendon.
Because of breakdown of collagen.
Yeah. But as we look deeper into that, what else could be driving that decreased stiffness? And some of this could be driven by the lateral gastroc, because some studies have looked at each individual tendon. They've noticed out of all the 3 subtendons, the lateral gastroc has less stiffness compared to the medial and the soleus.
What do you mean by that?
So like if they were to like look at like how stiff the tendon is, like each subtendon, the lateral gastroc has a lot less tension compared to the soleus and the medial gastroc tendons.
What does that mean clinically?
Clinically, it's a way of looking at the tendon isn't going to be able to absorb the force. That's where the weak point is, and that's what's starting to break down. Now, can we necessarily see it clinically? I haven't seen that necessarily, but what that could also translate into is decreases in strength or force production. You do see in Achilles tendinopathy that there's, especially insertional, is there's actually a decrease in the rate of torque development, so just how fast your muscles can produce force. So that could be where you're seeing that, and from a clinical standpoint, is more through those functional things, unless you had like ultrasound and like you're doing all that measurements and stuff. So yeah, clinically it would be more from the muscle's ability to produce force.
Got it. The only reason I ask is because I feel like when I'm doing manual therapy on a gastroc, I feel like I find more tender points and trigger points in medial head rather than lateral. Like a lot of people have more pain and I guess you could say tightness in the medial side.
So what that could be contributed to is there is altered motor control of lateral gastroc. So basically what was seen in a few of the studies is there's this increased discharge rate from the motor system. So basically it's like really trying to discharge the lateral gastroc to try and possibly accommodate this lack of stiffness, because it's now the muscle has to work harder. And there's a decreased de-recruitment threshold, which basically just means the muscle has a hard time or turns off a lot faster. So your muscles basically can on, off, like repeatedly, right? And I think what this could see is you could start to see it just start to fatigue over time. So possibly in that case where you're like, oh, we're getting a lot of trigger points elsewhere, those muscles are probably having to take over because lateral gastroc's going nuts over here. He doesn't know what he's doing.
Right.
So that's what I would almost say to that point, like, oh yeah, there's a lot of tightness there, because that could be taking over the duties that lateral gastroc, dog, you're all over the place.
So then it makes sense that we can treat the medial gastroc, but it's still going to continue to occur unless you actually get to the source of what the altered motor control is happening in the lateral gastroc.
For sure. And then I could see that also adding to more decreased stiffness, because now if your muscle's fatigued, it doesn't have really good tone to maintain contraction. So now maybe stiffness is even dropping more. And I said, so you'll see that again, rate of torque development starts to decrease. And as with any study over time, literature's always mixed. But in general, you kind of see a pretty good, like there is evidence out there that's showing decreased strength and decreased endurance of the plantar flexors in those with Achilles tendon issues.
Okay, so how do we address this in rehab?
So most of the literature that has looked at rehab tends to kind of gravitate towards eccentric exercises. And I think most people, even without not knowing the name of it, are pretty familiar with what I believe it's the Alfredson protocol. That's where they just said, do a ton of eccentric calf raises even if it hurts, and then just keep doing more and more as time goes on. That one's like pretty common in the research, and it's been shown to be effective. There are some issues with it, because one issue is compliance, right? It kind of hurts, so people aren't going to be like Yippee! I get to
can't
do
wait
that.
to do my rehab normally that doesn't hurt.
Yeah.
I really can't wait to do the rehab that actually hurts.
Yes. So
What do you mean I don't get to sit here and just get a massage?
Yeah, exactly. So it's now kind of thinking, okay, is that just the only way, or what else can we do about this? And there is actually some alternatives that can be slightly better or even have the same effects as like that eccentric protocol. And a really cool study, and you're kind of seeing this a little bit more with other tendinopathies, is just doing high loading on the tendon, just applying a high load.
Mm-hmm.
And the study looked at 12 weeks of high load isometric exercise. So literally I think it was like 90% of their max voluntary contraction. Like it was a fairly high load.
Mm-hmm.
And the results were pretty comparable to doing that eccentric protocol, if not superior in some things. So
I feel like isometric exercise is so underrated for tendons.
yeah,
Because I feel like people just jump to everyone here is like eccentric, we need to do eccentric, but I feel like you need to at least minimum start with isometric.
yeah. And I was actually just going to say that. Like if you have someone who's like pretty tender and like eccentric exercise is like kicking their butt and like their pain's really high, maybe starting with the isometric and just doing a high load could be super beneficial for them.
I mean, how I explain it to my athletes is your tendons need load.
Mm-hmm.
So what we're going to do in rehab is provide them progressive load.
And an optimal load, right? Because if you don't have enough load, the tendon's not going to adjust. Like you said, right? It needs load. And then obviously too much is probably why we were in this position to begin with. So it's it's that progressive optimal load.
Mm-hmm.
To just kind of,
too much load and not enough of the other muscles doing their jobs.
Yes, exactly. Another reason for that too is just, again, you're going to do it more, right? That probably feels a lot better than just blowing up your calf with eccentric work. To emphasize that high load thing again, they've even shown that just a slow high load eccentric exercise is better than doing low load eccentric exercise. So actually having more load on that eccentric exercise is more beneficial than if you didn't have enough. So clearly load is going to be what the tendon's responding to, and that's how it changes. And really where you see a lot of this benefit from, again, the high loading, the eccentrics, the isometrics, is the tendon will start to get more stiff. So the collagen is starting to repair itself. And that really is pretty like consistent to see that in like the short term of your rehab. But over time, as this is going, you'll actually start to see the cross-sectional area will get better. So less fluid's going to be accumulated there. Mm-hmm. The neovascularity is going to be gone, right? The body's like, hey, I don't need these new small blood vessels delivering things. Get on out.
I'm healing. I don't need more healing cells.
Yeah, exactly. And again, that's another sign of just good progression. But with insertional tendinopathy, this kind of adds a whole new wrinkle how you treat it. Because most people, when they think of those exercises outside of the isometric, like the eccentric, we're going like full dorsiflexion, you're on a ledge going into a stretch. But like we said, that could actually make insertional Achilles tendinopathy worse. Mm-hmm. So what has been advocated for that is basically you can still do your calf raises. You can even still do eccentric, but you're staying neutral. Mm-hmm. So basically, instead of dropping down, you're basically just on the ground, flat.
Or to add more load, you could do it where your toes are on the step still and your heel is off, but you're just not going into that dorsiflexion.
Yeah, you just don't drop it into dorsiflexion. You keep it neutral. Mm-hmm. That has worked really well. And then once that's getting better, you can progress them to more different ranges of motion. Again, stretching with insertional is really not great because of that dorsiflexion. Another thing that's been advocated for is heel lifts. Mm-hmm. Right, you can put them in a heel lift, and that'll help when they're walking, right? Because you do get into dorsiflexion when you walk. That can help alleviate just the day-to-day of just constantly irritating it. Or even rehab with the heel lifts you could do too.
Can you explain that a little bit? Because I feel like, doesn't that contradict you adding load on them?
Not necessarily because it would be passive, right? So if you put the heel lifts in the shoe, right, it keeps them in slight plantar flexion.
Mm-hmm.
So when they're walking, they're not necessarily going into that full dorsiflexion, so getting that compression. Does that make sense?
So you're still doing the same exercises, just more of it.
I mean, like you could do like, you can have them in the weight room doing like squats, like stuff like that.
Oh God,
Like you're still doing the calf raises to neutral.
Got it.
Yeah, you're not doing, we have a heel lift now, we can go lower.
Got it.
It's not like that. Yeah. It's just to prevent that, to truly keep them away from getting into dorsiflexion. The heel lifts would be able to do that day-to-day stuff.
We've started adding a lot of like RX pad, toes on the RX pad, heel lift off, and then doing movements with that, like lumberjacks or taking a kettlebell and going around your, like we call it around the world, but like around your shin, kind of like passing it back and forth, especially like basketball, back and forth, mimicking like that functional. We also will do like monster walks with their heels lifted, or you could even do split squats with the heel raised too.
Yeah, I like doing that with like advanced, like as they're getting better, adding that, especially because for soleus, because the bent knee.
I was going to ask actually if you saw anything, any benefit of training the soleus at like separately than the gastroc. Because like if you're doing like seated weighted calf raises versus like a standing calf raise.
Yeah, we talked about some of that, or some of the contribution from the soleus in the that first episode, and really what you see is you're seeing, I believe it was the soleus, like during gait, activates sooner than it normally would without Achilles tendinopathy. Again, probably for account for lateral gastroc, who knows what the hell he's doing. That could be why. So I could see, again, kind of that starting to fatigue a little bit sooner. So yeah, definitely I would try to train soleus as well. And also too, what people forget is, I feel like when we talk about like the calf muscles and the triceps, everyone thinks like gastroc, everyone thinks medial lateral, but honestly the soleus is actually a really big muscle, and it actually contributes a lot to our force, like our forward propulsion, and just like a lot of load through the ankle. So the soleus is actually very important to how the Achilles functions and just how we produce and absorb force. So yeah, I would definitely, and I do too in my rehab, attack the soleus a lot through stuff like that. I'll even, when they do calf raises, I'll even have them do them bent knee too. But yeah, then I also like pairing in like the split squats and then do a calf raise, or have them hold the split squat and then just bust out calf raises there.
Oh, I love, yeah. I'll do like, that's what I was thinking of, we'll have them do like a squat hold, and then like a 30-second like squat hold, and then they'll do heel lifts at that. Nice. I mean, it's concentric, it's not isometric or eccentric, which we talked about, but it's kind of getting that down. Like, it's getting the endurance portion. For sure.
Yeah, it would get the endurance portion for sure.
And then also just working full body, because we could go on and on about how important it is to work the glutes in this, and the core glutes, especially if you go back to that first episode when we talk about all that arch work and how the arch plays a role, especially in that braided rope.
Yeah, absolutely. And I think in that one too, we talked about the connection from the Achilles to the plantar fascia. Or maybe it was plantar fascia. I can't remember. But there is some connection that does actually, fun fact, go away as you get older.
Oh, really?
Yeah. It's crazy.
That's like how, like when?
I can't remember. I know it's like definitely like older adult. So you're talking someone over 40, over 50 is when they really don't have that connection as much between the Achilles and the plantar fascia anymore.
Interesting.
Yeah. There is another thing you could do with your rehab as well, is because again, we're talking lateral gastroc's a disaster, just at what's happening. You can actually tailor your calf raises to start targeting lateral gastroc, and I believe it's toes out. Will kind of focus more on lateral gastroc.
Okay, I always see this of like the heels out, toe, like heels out or heels in. Like, I don't understand how it targets the calf, one side of the calf more because I feel like because the hip is the one internally or externally rotating, I don't understand how that is coming from the calf.
For sure. I saw studies reference it. I didn't actually read those ones, so I don't know why that happens. I do need to look at that. But I do remember seeing that, yeah, that was one way that you can actually get more activation out of your lateral gastroc compared to the rest. So if you're really like, I'm going to teach lateral gastroc who's boss and get it back on schedule, that would be a way you could do that.
Could you do Russian stim with the lateral gastroc while they do calf raises?
Yes. But I haven't seen anything that did it, but theoretically, yes. That would be the same idea.
Okay. I feel like this could be the action item.
Oh, I was going to say for action item, just really be like, know what you're dealing with, right? Whether it's midportion or insertional, because it does really kind of change, what you're going to do with them. And then don't be afraid to load them when you're rehabbing them. And obviously, I tend to be a little more conservative with my like eccentrics, right? Like I think research says like, oh, they could be up to a 7 out of 10 of pain. I'm like, oh, that's brutal. Like I'd like to keep mine like, hey, as long as it's, I tell them, if it feels uncomfortable, that's okay. But if it's excruciating pain, let me know.
I just got a form.
That's a good one too, right? Like if they like because of pain or just like if it looks not great, it definitely isn't great.
Right. I tell them that tendon rehab is the worst rehab that they're going to do. It's
fair.
And that usually I'm not okay with pain in rehab, but I'm okay with pain in tendon rehab.
Yeah. That's why I give the wiggle room of uncomfortable. Hey, like it's not going to feel great, but I also don't want them like, oh, this is like excruciating pain. I'm like, okay, well,
yeah, if it's going to make it worse.
Yeah, we're not trying to do that.
Did it say anything about activity modifications?
You're okay to stay in daily activity up to 5 out of 10 pain.
What about like sport?
5 out of 10 pain. Like they could still participate in whatever they're doing.
So we're not making it worse if they're
correct.
If they're staying under like 5 out of 10.
Yeah, that was kind of their barometer. It's like, hey, if you're staying around or under 5 out of 10, you could still do those activities. But if an activity increases that, then that's what you want to avoid. So it's a total rest isn't necessarily beneficial. I mean, I guess if it's like your tendon's super blown up, you can't do anything without intense pain, then yeah, probably.
Yeah, don't rupture these guys.
Yeah, some rest will probably be needed. But yeah, as long as they're 5 out of 10 pain, they can do those activities. And again, same thing, like the heel lift for the insertional might be able to help keep them active while they're rehabbing and treating it.
Heel lift or Achilles tendon tape.
Yeah, as long as it's restricting the dorsiflexion.
Mm-hmm. Well, cool.
Yeah. That was our first update episode. I was really excited about that and really thinking like how cool that it's been that long that we could actually
half a decade.
Yeah, that we could actually look at what literature has come out since our last episode and how does that, like, I don't know. That's really nerdy, but I thought it was really cool.
That is really cool. So if you are interested in claiming this as a Category A CEU, again, go down to the show notes, click on that clinically pressed link. It will take you to the course. You can enroll in it. If it's within our latest 5 episodes, it will be free. If it is not within our latest 5, it will still be really affordable. And again, you will help support the show. So once you're enrolled in the course, it will you can watch the episode and claim your certificate. So if you guys have any questions, just reach out to us or go to our Instagram. We have a whole tutorial online. And if you are new, we actually have different types of episodes other than CEUs. We have a lot of interviews this season. We've actually recorded a ton already. So we're super excited to share those throughout the season. And we also have story episodes where we take stories from real life athletic trainers and we bring them to you about a special highlight topic, which is just fun to hear other people's experiences. And we're super excited to bring you so much in season 6. So thanks for tuning in. Do you have anything else, Randy?
Nope. Thank you for helping us showcase athletic training behind the tape. Bye.